Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research-based information about cancers and their treatments. Hello, I'm your host, Dr. Prasad Dandekar. I'm an oncologist and I head the Radiation Oncology Department at Sir H. N. Reliance Foundation Hospital in Mumbai. Clinical research is something that we live and breathe by every day as oncologists, and lots of our patients have many questions around it. Today's guest, Dr. Indranil Mallick, is a perfect guest for all your questions that you may have about evidence-based medicine and clinical research. Welcome, Dr. Mallick.
Thank you, Dr. Prasad.
Dr. Indranil is a clinical oncologist at Tata Medical Center in Kolkata, and he's very actively involved in the clinical research. He also heads the Research Ethics Committee at Tata Medical Center. So welcome, Dr. Indranil, and we're really curious to know all about medical research and clinical research from you.
Thank you. It's lovely to be on your program.
So, Indranil, as a clinical oncologist, you and I every day face this problem where the patients are so curious. When I tell them a particular treatment, the first question that they have is, Doctor, why are you suggesting this treatment? And then we get into this conversation about what is medical research and what is clinical research. And many of them find it rather confusing. What has been your experience in this regard?
No, I think I share your experience, Dr. Prasad. I think that, for patients to understand the nuances and all the dimensions of clinical research is obviously very challenging. They are in a very vulnerable position. They are often facing a dilemma in their course of treatment. Sometimes the outcomes of future treatments are not clear. So they often read about clinical research. They're not sure whether their doctors have time to answer all their questions or not. So I can totally understand that research for patients is a challenging topic. And I think they definitely need more help and more guidance in understanding this.
So when we talk about clinical research, I'm curious about what did draw you into the clinical research practice? Not many of us are actively involved in clinical research. What got you interested?
Well, I think it was, my environment more than anything else. I had the, good fortune of training in institutions where research was very much a part of what we did in our daily lives. As doctors, and when we train or when we specialize in a particular subject, we often have to do what is known as a thesis. And, it was in my case, it was actually, doing my thesis that got me really hooked on to the concept of research, because I understood through the process of doing a small clinical research project as a part of my thesis, that research has so many dimensions. It can challenge you, and it can really draw you into doing something that makes a difference. And you will appreciate that the way we used to treat patients when we were training a couple of decades back is quite different from how we treat our patients today. Oncology or cancer treatments are changing all the time, and unless we embrace that change, and by embracing that change we basically mean answering new questions through research. Unless we do that, we cannot really push this domain forward. Cancer is a life-threatening disease. If we want to cure patients, you have to seek better answers, and research is really the avenue to seek those answers.
So recently I had a patient who had a laryngeal cancer, and the cancer had sort of gone out of the larynx, and the obvious suggestion to her was doing chemo radiation together. And I said, we need to treat both sides of your neck because there's a chance that the tumor may spread to both sides of your neck in the lymph nodes. And the patient was not keen at all on irradiation of the neck. They said, we just want to treat the larynx. Why do you want to treat the neck? And I had to sit them down and I had to tell them that, there is a chance that it may spread to this part of the neck, it may spread to that part of the neck, and the percentages. And I could see the confusion grow on her face as we started talking about percentages. Do you want to sort of help us understand when I say there is a 30% chance of relapse of the disease? What does that actually mean? Because patients hear that very differently than what you and I mean.
No, I think you're spot on. I think that this is one aspect where we are often not very clear to patients. When a physician says that you have a 30% chance that your disease will, say, recur, or there will be a recurrence of your cancer, what basically the doctor is telling you is that if we treat 10 patients, then 3 patients out of those 10 will have a recurrence. The remaining 7 of them will remain fine. And it's not like 70% of your disease will go away and 30% will remain. It's basically that 3 out of 7 people will have a recurrence.
Yeah, and I think what, as doctors, we need to emphasize also, if you are one of those 3 who are getting the recurrence, then there's absolute 100%, you have that recurrence. It's not partial. In oncology, either you have cancer or you don't have cancer. It's 0 or, 100%. Because most patients get confused. They said, oh, but there is only 30% chance, 70% chance of cure. And I try to explain them exactly how you did it, that if you have 10 patients, and then we don't know whether you are going to be in the 7 or you're going to be 3. And that is where we are currently. Maybe in the future, and the way our molecular studies and genomics are going on, maybe we'll be able to classify the patients better and better as we go along, who will benefit, who will not benefit. But as of now, we are still sort of going by what is the data and the evidence that we have. So
Yeah.
when we say data, then again, there's this confusion. How do you explain your patients what data means and what evidence means?
Yeah, I think that the way we need to communicate with patients is that we need to tell them that our knowledge about the outcomes of their treatment really depend on what researchers have published in what are known as peer-reviewed journals. By that, we mean that these are journals, these are respected publications where researchers submit the results of their findings. Sometimes these findings are just audits. So they're simply tabulations of what happened to patients they treated. And sometimes these are results of properly done clinical trials, which are asking a question and trying to answer that question in a stepwise or a robust manner. And from these publications, which are then reviewed by independent experts, these are by a process called peer review. The results which are most robust are published in these journals. And this forms the basis of our knowledge. And it's from these publications that we explain to patients what their outcomes may be.
Now, one of the things that has happened is because of the internet access, there's a lot of democratization that has happened about data. Earlier, even we did not have access to proper journals unless you worked in a hospital which had spent money on subscribing to a particular journal, and then you went to the library, found out which journal, which paper, you opened it, then you photocopied it, and then you could see that paper. Now, with just a touch of fingers on internet, you have all the data available. If the journal asks for money, it's like small amount of money which patients can pay. But if you go to websites like Google Scholar or PubMed, a lot of research is available. Now, that sometimes becomes a problem because anything that you type, there'll be some paper published. Like if I type literally, can drinking milk cure cancer? I'm sure somebody would have said something about it, right? So how do we sort of make sense of the amount of data that is available? How do we select the right data out of this?
Yeah, I mean, I don't think it's possible for patients to directly, derive this data by looking through journals, unless they are trained or they are scientists who are used to doing this kind of, curation of data. I think that to a great extent they'll have to depend on the judgment or on what their doctors are telling them. Now, how doctors do it is through a process of categorizing or reviewing the publications and putting them into groups, uh, which are or what are known as levels of evidence. So depending on what we are reading, we can identify whether that evidence or that result is something that how robust that is and how applicable to clinical practice that is. And we can also say that has it really found something that is of meaningful or what we call as clinically meaningful benefit for patients. So that only comes with a certain amount of training that we do as oncologists under the guidance of our teachers, and some of it has to do with very specific education or training that we receive when we are researchers ourselves, and we are taught how to how to analyze or how to see how good the results of a clinical trial is. So depending on how the clinical trial has been done, or the type of paper that is, we can categorize these publications into what are known as levels of evidence. So the highest level of evidence is either a large trial that has randomized patients or kind of divided patients into two groups or two or more groups randomly, given them one group one treatment, the other group another treatment or a new treatment, and has carefully analyzed whether there is a benefit of doing the new treatment versus the old treatment. And sometimes there could be several clinical trials that are testing the same type of treatment, and then we have some researchers will get together and will combine all these trials into what is known as a meta-analysis, and they will summarize the results of these trials and give us an even better idea regarding what is really good and how much benefit a new treatment might offer. Yeah, so that is the highest level of evidence, or what is known as level one evidence. And then there is, of course, other levels of evidence when we have smaller studies that are comparing two treatments, or just a study that is designed to just test one treatment without a direct comparison. They fall into a slightly lower level of evidence. And the lowest level of evidence is something that people just publish, what are known as retrospective publications, or they just look back at the results of the treatment that they've given to their own patients, and they try to see patterns. Okay, so depending on how well a study has been conducted, we generally get an idea about the level of evidence. The higher the level of evidence, the more trustworthy and more reproducible that is. And that is usually what the doctor will advise the patient to do. The higher the level of evidence, it will come into clinical practice guidelines that help the doctors find what is most appropriate for the patient.
Indranil, one level of evidence I think you missed, and which we must inform our patients, and which is unfortunately the most common level of evidence, which is evidence based evidence, which is unfortunate. In India, people would say, in my opinion, this should be done, which is actually has no correlation with research. There's no logic, and the doctors will just tell the patients, I want to do this to you because I think so. In my experience of last 30 years, 40 years, whatever. And this is dangerous. And that is, I think, our patients need to understand very well. Eminence based medicine or somebody telling you that I feel you should do this is not the right advice. There is no feeling to data. Data has no feelings. Data is data. Data is the truth. And we must seek that truth about your treatment through good clinical data, whether it is meta-analysis or clinical research. And in some, I mean, in common cancers, of course, now we have very good data available. You talk about breast cancer, head and neck cancer, lung cancer, there's excellent data available. And in smaller uncommon tumors, we may not have level 1 evidence, but we have to go by whatever evidence we have. And, I'm sure in Kolkata also, Indranil, you must be seeing patients who have been seen by other doctors where random treatments were advised.
Yeah, I think that when doctors become experienced, they fail to distinguish between what their feelings are, what their emotional approach to a particular situation is versus what is supported by good research or what is known as good data. And there is a term for it. It's called bias, and a bias is not something conscious always. It is an unconscious feeling that we tend to prefer one approach to treatment versus another without the support of properly done studies. And this is very common, and we are all prone to it at one point or the other. So that is why the whole framework of research and levels of evidence exist, is to remind us that we should not get swayed by our bias, and there is a way to categorize what is the right approach based on the strength of the research behind it.
Yeah. And the bias is very tricky. Our mind is such that we don't know that we are being biased. I'll give you an example. Now, radiotherapy and chemotherapy has become standard of care for laryngeal cancers. We treat so many laryngeal cancers, and we call that as an organ preservation protocol, where we don't have to cut open the larynx and remove it. Once the patient gets cured with chemoradiotherapy, it's excellent outcomes. They have their voice box, they're able to eat, swallow, everything normal. One of the surgical oncologists I work with would consistently say, but Prasad, if you give chemoradiation, they relapse and they have really bad time. And when they come back to me for surgery, it's really difficult to do the surgery. And I heard that for a while. And then I realized what was happening. He is an excellent and very experienced surgeon. So all the difficult cases were coming to him. So he was seeing an unusually high number of patients who all other doctors had said, I cannot operate or, have relapses. So they were coming. So he was not getting a picture of what is happening to all the patients. He was only getting to see patients who had been, who had a recurrent disease and were difficult disease because he was so experienced. So when I made him aware of that bias, things improved. But that is the sort, how our mind works. It's really crazy.
Yeah, you're right. I think that we all have seen this happen. We get tricked as well. We are not immune to this, and it's only when we and one of the ways to overcome this tendency to have a personal bias is that we in most hospitals now, especially in cancer centers, there's something called as a tumor board or a multidisciplinary meeting. And in these meetings, we have experts, sometimes several experts belonging to a particular specialty. And this group will often, have counterbalance our personal biases, and they will, challenge their colleagues with the evidence that has been published. And that's always a very, very good way to, make treatment decisions for patients.
Yeah. And I think patients need to insist, like we also run a tumor board, and every Tuesday in the morning, and we sometimes invite patients after the tumor board is over, and we all meet them and we explain them what did we discuss. So the surgical oncologist, the medical oncologist, the radiation oncologist, the tumor board also has nuclear medicine specialists, radiologists, pathologists. We have, of course, our students and everyone. So we're like 20-30 people in the meeting, and we discuss these difficult cases and come up with very innovative solutions many a times, which probably one person could not have found. So patients also, I feel, need to demand that if they go to an oncologist, and if it is a standalone oncologist, I think that itself, in my mind, and I'm again could be biased, is a red flag. I don't think cancer care can be done by one individual. It is a team effort, and you need different types of oncologists, different types of doctors, speech therapists, physiotherapists, so many people. It takes a village. So I think that is something that our patients need to understand, that you need to go to an institute which has all these specialties. And then, if your case is particularly complicated, insist on your doctor that discuss this in tumor board, and then let us know what your board thought. And that will be a very good way to make sure that you get evidence-based treatment.
I totally agree. I think that a multidisciplinary tumor board is an absolute must in any cancer patient's journey. I think it's not just the difficult cases. I think as many as possible, practically every single case, if possible, should be discussed in a tumor board, just to make sure that things are happening to what is known as current standard of care.
Indranil, this afternoon, I had such a difficult time in my clinic. I saw a patient who is just 32-year-old. She had breast cancer 2 years ago, got the treatment done. She had breast conservation surgery, and then she had her chemotherapy, and she received radiation. And then in the course, the doctors figured out that she actually has many strong history of family history of cancers. Yeah. So they got her BRCA test done, which is a gene which can predict if you will have genetic hereditary cancers, and it was positive. So she actually underwent removal of both her breast, removal of ovaries, removal of uterus, and then she was fine. 2 years went by, nothing happened, and now she came back with sudden onset fits. She had seizures, and we detected that she has now multiple lesions in the brain, multiple tumors in the brain and in her body. And she was devastated. She said, "Doctor, I did everything that was told to me by medical team. Why do I have this cancer back?" And then she asked me the most difficult question: what is my survival? How much will I survive? And it's such a difficult question for oncologists to answer. What do I tell her? I know that she has limited time. But how do I use my data, what I have about, what my knowledge and data is about this, to explain that to the patient? How do we use data to make things easier for our patient? What has been your experience?
Yeah, I think this is a really challenging situation, and I personally, I'm not very sure that a number appropriately conveys the message or the information that a person seeks. I think in these situations, it's there are different approaches to breaking bad news or giving an appropriately worded information to patients. But generally, it's generally a good idea to be honest about the fact that what are the treatments available right now. And when we talk about the time that a person is supposed to live, we generally, as doctors, we communicate with each other through what is known as a median time. Yeah, and now that is sometimes very difficult for patients to understand. And so when we doctors say for example, the median survival time in a particular situation is say 9 months, what we mean is that we don't know what is going to happen to you as a patient, as an individual patient, but we know that if there were, several patients like you, then a half of them would live longer than 9 months, and half of them would live shorter than 9 months. But generally, we cannot tell you how long you will live. And it's probably not a good idea to focus on the exact number of months. But what I tell the patient is that it's how you will spend the rest of your time, no matter how much time you have left, is what matters. So this is a time that is in your control, and you have to decide how you will, whether you will push yourselves towards treatment, or whether you want to, spend the rest of your time doing things which are much more meaningful to you than coming back repeatedly for treatments, etc. So these are some of the things that you have to bring into the conversation, depending on what an individual's circumstances are. And
Yeah,
often,
that's what.
in these circumstances, people will probably ask you about new treatments and about clinical trials. And now that you mentioned this particular story, I'm reminded of a recent meeting with this gentleman. His name is Vivek Tomar. Now, if you look at the internet, you'll find a lot about Mr. Tomar. Mr. Tomar, leads a patient support group which is known as ALK Positive India. Now, this group was built in support of his wife, a young lady who had a metastatic lung cancer. Now, he realized that when his wife got diagnosed with metastatic lung cancer, that there were very limited treatment options for this particular situation. Now, he just happened to understand that, find out that his wife had a particular type of lung cancer, which is sensitive to, certain drugs. It had a particular, mutation, and it was sensitive to certain drugs which were not easily available. So he actually, started campaigning. He and his wife, they started campaigning for bringing in clinical trials, which were, going on in Western countries, into India, so that patients in India could participate in these clinical trials. And then he had this amazing journey alongside his wife, and they went through a very difficult process of convincing regulators, convincing the government, convincing the drug companies to bring their trials in India. And uh, not all clinical trials are successful, but his story is that his wife actually went through several of these trials before ultimately she passed away. But she had a very fulfilling life. They ran marathons together, etc., etc. And it really changed even my attitude. I participate in a lot of clinical trials, but it made me look at clinical trials in a different way. Sometimes I'm sure you have the same problem, is that it's very challenging to explain what a clinical trial is to patients. And it's very heartening to see that the other side of the story, when patients realize that clinical trials can be very meaningful for them. I don't know what your experience is in this regard.
Yeah, absolutely. I mean, clinical trials are now, a sort of savior, because back when we were training, the patients were not surviving that long because the treatments that we had were so limited. Like when somebody got diagnosed with lung cancer, even if it was not metastatic, which means it had not spread to other parts of the body, it was almost like a death sentence, right? And now we have so many drugs where the patients are surviving longer. We have so many different types of chemotherapies. You try it type number one, number two, number three, number four, whatever. So patients are surviving much longer. And then there is a point where we don't have any drugs available for this patient. Patient is doing well. I have a gentleman who has lung cancer. I treated him 8 years ago. And at that time, it was metastatic. So it had spread to other parts of the body. And I can't remember how much we have treated. I mean, he's been on this treatment, that treatment. We have treated radiosurgery for his brain lesions, for lung lesions, spine, and he's been on so many different drugs. Now, he is doing well, complete cognitively, absolutely fine, but there is progression of the disease. And now we have nothing left. Like there is no drug which he has not taken. So this is the area where clinical trial becomes really important, that I wish we had some clinical trial where we could enroll him and we could try a new treatment, a new drug. Unfortunately, there's nothing in sight for him because there is no good clinical, so he does not have markers which can be tried in clinical trial. But Indranil, when we talk about clinical trial, I want to highlight one point because I do see a lot of patients who go abroad to participate in clinical trials because you have a lot of avenues available in large institutions in US and UK and other parts of the world. But sometimes the patients misunderstand what a clinical trial is. Because clinical trial, especially for a new drug, they feel that if they participate in that trial, that means they will get better. And you actually alluded it to earlier that clinical trial is actually a trial. We're trying things out. The trial could show that the new drug is better than the old drug. It may show that actually the new drug is worse than the old drug. And it may show that there's no benefit at all whatsoever. It just doesn't have any action. Or it may have more toxicity. So this is something I think the patients need to understand, that when you participate in a clinical trial, please be aware that you may benefit, but there is a chance that you may not benefit also. So when you consent, you need to be aware of this.
Yeah, I think that it's probably worthwhile if we have a little bit of time to explain the process of clinical trials to our audience. Is that when say for example a pharmaceutical company devises a new drug or comes up with a new formulation, they have to go through a long journey, and it's important to go through that journey precisely because it is very important to make sure that the drug that they think is going to benefit patients or they hope is going to benefit patients is actually first safe, then effective, and then hopefully more effective than what is available to the patients right now. So when a pharmaceutical company devises a new treatment, or even a technical company or a gadget company, or say a surgical robot company or a radiotherapy company comes up with a new solution, ideally it should be tested in a stepwise manner. So it's relatively easy to explain for drugs. So let's quickly explain it to our audience. Is that the first step when a company comes out with a new formulation is that they first have to check the safety and of the drug or the effect of that drug in animals. And once they find that there is possibly a benefit in animals, that the tumors in animals, in mice, and in monkeys or whatever they're trying it on, the tumors are shrinking, for example, then they transfer the trials, or they move to human studies. And the first step in trying the drug in humans is what is known as a phase 1 clinical trial. In a phase 1 clinical trial, you simply check whether the drug is safe. Yeah, this is a very important step, because if the drug is not safe, then no matter how good it is, it's of no benefit. So the first thing is the drug safe? So in a phase 1 clinical trial, what they check is what are the side effects of the drug, is it safe, and what is a safe dose of the drug to try on patients. Now, once they have found that, and that the drug is safe, and they found what is a correct safe dose, they have to then start a new trial. And in that new trial, which is called as a phase 2 trial, they check whether the drug has a benefit to the patients or provides a benefit. Is it shrinking the tumor? Is it making people disease free for a period of time or not? And these are all steps which are important, because if they find, for example, that it is shrinking the tumor, but it's not shrinking enough number of tumors, or it is keeping the disease safe, but it's not really showing any sign of being better, for example, just by looking at it, it's probably just a little worse than what we usually have for our patients already, then these drugs are no longer taken into bigger studies, no longer offered to other patients. It's only when the phase 1 and the phase 2 trials show very encouraging results is that the company then will try it in a much bigger setting, in what is known as a phase 3 trial. And a phase 3 trial is very important, and it's compulsory before a drug is approved by the regulating agencies that approve drugs. And in these phase 3 trials, the new drug is compared with what is known as the current standard of care, whatever is the current best treatment. And it's done in a particular way by dividing a group of patients into two groups. One group receives what is current standard of care, one group receives the new drug, and who goes into which group is not decided by the doctors or the patients, to reduce what we previously described as bias. And it's only when such a comparison, that sometimes the comparison like this and obtaining the results can take a few years, only if there is a clear benefit of the new drug will the new drug be then approved by the drug regulating agencies. And it's only then that it will become available for use in, to doctors like us, for patients who come in our clinics. So all of these steps will sometimes take 10 years, 15 years from a drug, starting from the first study to obtaining the results of the final study. So it's a long journey, but it's a journey that is very important, because without going through the journey, we are not sure whether a new medicine is going to be beneficial to patients. This is very unlike what happens in traditional medicines. Yeah, in traditional medicine, it's basically wisdom passed over the ages. There's no burden of proof. You are basically showing anecdotes rather than properly done comparisons, and that is why people have a lot more faith in the system of medicine, of modern medicine that we practice, and many more patients come for the proper modern medical treatment than they go for alternative medicine, is because we go through a process. And this entire process, or this journey that a drug goes through, is a process also in which the patients participate. So when patients are participating in clinical trials, they're helping doctors and the medical fraternity find the correct answers. And many of these trials are negative. By negative, you and I mean that they don't find success. And that is fine. I mean, you will only succeed if you try, and sometimes you will fail. But at the end of the journey, you have trials that have moved this, the field of oncology forward to an unimaginable extent. I mean, the survival rates of many cancers have completely changed because patients have participated in structured studies. And some patients have not done well in those studies, but other patients have. And it's an acceptance that patients must have, that some of the clinical trials in which they participate will not produce the right results, but some of them will.
Yeah. And the treatments have also changed because of this, because so many patients trusted their doctors to do the right clinical trial. I mean, one stark example that comes to my mind is the breast radiotherapy. When we started our residency, we were giving 31 radiations to the breast. Then came START A, START B trials, which were done in the UK. And they said, actually, you don't need to give 31 radiations, 20 radiations are enough. And then we started giving 20 radiations across the globe. And then bang on, just at the beginning of the COVID, the fast forward trial got published. And that was such a landmark trial because it said, actually, you don't need to give 20 radiations, 5 radiations are enough. So just in the span of 2 decades, we came from 31 to 20 to 5. And it's such a big change because for a patient of breast cancer, I'm telling them now, instead of taking radiotherapy for 6 weeks, you just take it for 1 week, or not even 1 week, just 5 days before you know the treatment is over. So the access to the treatment has improved, the tolerance to the treatment has improved, and the patient's sort of acceptance of the treatment has also improved, all because those many hundreds of patients participated in those studies, and those doctors did those studies well and then published them in very good medical journals. For people like you and me to then extend that treatment to our patients. These studies were done in the UK. And then we are treating our patients with those studies because those results were so robust.
Yes, and yeah, so you have highlighted a different group of trials that, excuse me. So yeah, you have highlighted a different group of trials, the trials that are not promising to provide better outcomes, but they are trials that are simplifying the process of delivering that treatment. They're making the treatments shorter, they're making the treatments less cumbersome, and these are also sometimes equally meaningful for patients, because the journey that the patients have to go through is often pretty long, expensive, arduous, and anything that reduces the cost or the time that a patient may require to go through a treatment is something that is often very, very meaningful for them. In India, this is even more meaningful because many patients often come from outside cities that are where they're getting their treatment, and therefore the time away from home, the time that their carers have to spend away from work, etc., they're all very important.
Absolutely. So, Indranil, would you use some resources for your patients? How do you disseminate the information about treatment that you're proposing to your patient?
Uh, do you mean new treatments, or do you mean the usual treatments what is current standard of care? If you're,
Yeah.
I mean, the current standard of care is generally outlined in what are known as clinical practice guidelines. Now, one, sorry, every now and then there will be an updating of these guidelines. So these guidelines outline how patients in different stages of a particular disease should get treated and the supporting evidence for these. So when we explain to the patients, we generally outline that, based on the current best evidence, the current treatment guidelines suggest that this is the best treatment for you. You need to get radiotherapy after surgery. You need to get 5 treatments instead of whatever 25 or 30 treatments, and this is the current standard of care. And because it has gone through a process of curation in a systematic manner, it's easier for us to convey that to patients.
Yeah. So I often use NCCN guidelines in my practice, and now it's so easy that either just take a screenshot and print it for our patients, or we encourage them actually to go on to NCCN because they also have the patient information on their website, and that sort of again what I was alluding to earlier, democratization of the access to good treatment and evidence-based treatment. So in our today's episode, in the links we will put some links which will give access to what are the current guidelines, what sort of information that the patient should be looking at before making their treatment choices.
Yeah, that would be very, very useful, I think.
Yeah. So, Indranil, how should our patients select the treatments that have been recommended? Because it is not very rare for you and I to give an option. So, one of the common treatment dilemma that my patients have is prostate cancer. Oh my God, I have lost count of how many patients I have counseled. Early stage prostate cancer patients have option of either undergoing surgery or taking radiotherapy. The advanced stage patients don't have that option because their surgery cannot be done. They have to undergo radiotherapy. And when the patient goes to the surgeon says, you must do the surgery. And when they come to radiation oncologist, we are like, okay, you have these two options. What do you want to do? And it's very difficult for them to choose. And many times, like today, one patient told me, but Dr. Saab, आप क्या करेंगे आप यहाँ पे होते तो. And that's a trap I always avoid. I said, with all due respect, I am not there. My job is to give you and empower you to take that decision, and you have to take that decision considering all the factors that you have. How do you handle that in your clinical practice?
Yeah, I have the same problem that you face, and that is that in some situations, like this particular scenario, is that patients have treatment options that are comparable. Now, fortunately, in my clinical practice, what we usually do is that the patient compulsorily in our institution meets both the surgeon and the radiation oncologist, and we encourage the patient to take a cross consult. So I would ask the patient to meet the surgeon also before coming back to meeting me, etc., etc. Now, the way that I would deal with a situation like this is that I would tell the patients that sometimes you have two equally good treatment options. You're trying to decide whether you want to buy a Mercedes or you want to buy a BMW. Now they're both great cars, and the real choice is in the details and the nuances of these cars that you prefer. It could be a choice between cars or a choice between two TVs or whatever. And then I outline a few thinking points for the patient, and I say that if you're these are the differences between the two treatments in terms of the side effects, in terms of the cost, in terms of the changes in the lifestyle that these treatments entail. And then I tell the patient that, look, I've explained this to you, but at the end of the day, it's your call. And no matter which decision you make, it's the right decision, right? And we are never going to question you. We are not going to come chasing you and say, okay, you didn't do this, that is why I'm not happy with you. Saying that we will be happy for you as long as you can make your choice, and we'll be right there behind you and try to do the best for you. So that really helps patients. Now, unfortunately, that is only possible in large institutions like yours or mine, where your colleagues are always discussing or they're working as a team. It's a little bit more difficult in one oncologist scenario where they don't have that institutional support.
Yeah, indeed. I mean, that is where the point of going to an institution which has a comprehensive cancer care available is very, very important. So, Indranil, I think today's conversation was fantastic. We covered a lot in terms of what is evidence, different types of trials, and how should patients make those choices. I'm sure it will help us to help our patients to get the right treatment, the evidence-based treatment. And I'm hoping that patients who see this and hear this podcast will feel more empowered to take the right decision. And this is one step that you and I are taking towards this fight against cancer, where we empower our patients to improve their outcomes in not only in terms of survival, which is very, very important, but also in terms of quality of life, the toxicities that they face, and whatever other issues that they may be facing. So thank you very much for sparing your time. It was a pleasure, and always a pleasure to talk to you. And I'm really happy to have you on board as a guest. Thank you.
Thank you, Dr. Prasad. I really enjoyed this discussion. This is an ever-evolving discussion about clinical research, and I really hope that the listeners in the podcast have benefited a little bit in listening to us talk. Thank you.
Thank you for joining us today. I hope you find today's episode informative. Please feel free to ask your questions in the comment section, and we'll get back to you with the correct information. Please do like and subscribe to the channel, but more importantly, share this information with people you care about. Join me in this fight against cancer.